Let's shine by seeing the best in all of us and by looking out for each other. Let's stay healthy. Let's shine together.
Hi, I'm Sharrie Harlin, program host for Let's Talk Together. Excuse my voice. I'm drinking tea today, so we're going to really rely on my guest today, which is Dr. Andrew Spoljaric, and he's a neurologist with Reid Health. Welcome.
Hi, Sharrie. Thank you very much for having me.
And before we get started, how did you come to Reid?
Well, I'm Indiana born and bred. I was born and raised in Northwest Indiana. Went to Munster High School and Wabash College in Crawfordsville, Indiana, and then IU Medical School. And I went from IU Medical School to private practice on the north side of Indianapolis in Kokomo, and practiced there for the last 20 years. When I started practicing private practice, my wife and I had a son, and he went off to college a couple of years ago, and so my wife and I started to look at what do we really want to do with the rest of our lives. And so we wanted to move out to the country, and we wanted to Reid fit the bill for us to get out, and came here to practice neurology and serve the people of Wayne and surrounding counties.
Well, thank you, and we're excited that you're here.
Thank you.
A little rural living, so.
Absolutely.
Hats off for that.
Thank you.
Today we're discussing Parkinson's disease.
Absolutely.
And exactly what is Parkinson's disease?
Well, Parkinson's disease is a neurodegenerative disorder, which is to say that it results from neurodegeneration, which is, for lack of a better term, breaking down of normal structures and loss of proper or biological patterns in the nervous system. It's also referred to as a movement disorder frequently, because usually the way people start to notice Parkinson's disease is that the way that they move changes, and they start to move differently. They start to move more slowly. They frequently have a noticeable tremor, and so it was originally called a movement disorder, and it still belongs to a part of neurology called movement disorders, but it also has non-movement related symptoms. Those have, over the last few years, become identified as targets for different sorts of treatments, and we'll talk a little bit more about motor and non-motor symptoms as we move through the talk today.
And a little about the history of Parkinson's disease.
Yeah, Parkinson's disease was first described by Dr. Parkinson in the early 1800s, and he wrote a paper called An Essay on the Shaking Palsy. It wasn't until over 100 years later that we started to realize what was going on with this condition. 130 some odd years.
Wow.
A very brilliant pharmacologist, Swedish pharmacologist named Arvid, I think Arvid was his first name, Carlson, discovered in the 50s that dopamine was in fact a neurotransmitter. Dr. Carlson just passed away 6 years ago at the age of 95, and was a very important contributor to figure out that dopamine was a neurotransmitter, and that certain things, specifically the drug called reserpine, would deplete dopamine and cause the symptoms of Parkinson's. This led to the discovery that levodopa could be given to patients with these signs and symptoms of Parkinson's, with frequent improvement in their symptoms. And in the 80s, there was a group of people that were experimenting with kind of what you call the designer drug market. And this drug that was designed to be a replacement for opiates turned out to be a neurotoxin, unfortunately, and it caused Parkinsonism in these folks. So we found a way to make laboratory animals Parkinsonian so that we could treat them and do research by use of this substance called MPTP.
And one of the things you brought up were the motor symptoms.
Yes.
Can you discuss that, please?
Absolutely. Absolutely. So Parkinson's, we frequently, I like to use the word trap as a way to remember the symptoms. And when I sit down with my patients in the office, I'll talk with them about the trap of Parkinson's disease. And trap refers to the tremor, rigidity, akinesia or bradykinesia, which means diminished movements or slowness of movements, and then postural instability, which means impairment of balance. And these are the four kind of hallmarks of Parkinson's as well. And the tremor is frequently a unilateral, meaning one-sided tremor. It tends to be a coarse, resting tremor as opposed to a high-frequency, low-amplitude tremor like you see with an essential type tremor. So it's pretty easy to distinguish it when you see it. I frequently tell my patients that Parkinson's is kind of like pornography. You know it when you see it. And it's a clinical diagnosis. And so other motor symptoms include walking patterns, and you see kind of the standard stiff, small step gait, shuffling sort of gait. And sometimes they also have other sorts of movement disorders like dyskinesias or those sorts of things as well.
The tremors are probably the biggest thing that people see.
Frequently, that's what brings them in.
And that was interesting how you brought up. It's not straight out. It's usually even when you're resting. You're shaking.
Yeah, that Parkinsonian tremor is, the hand when it's at rest tends to be, they describe a pill rolling tremor, or like you're rolling a pill between your thumb and your index finger, or that at rest. And I always ask, sometimes I'll ask the spouse if they're there with their loved one, do you notice the tremor more when they're distracted watching a football game? They set down the remote, their hands are resting. That's when you'll see the tremor more so than if you're reaching for the remote. Which again would separate it from more of an essential type tremor.
And now, what are some of the non-motor symptoms?
Well, and that's really been it's interesting. I didn't consider myself old until recently, but.
Tell me about it.
But it's interesting how things have changed. The trap, the tremor, the rigidity, the akinesia, and the postural instability really was the hallmark of Parkinson's disease when I was in training. We didn't talk about depression. We didn't talk about psychosis or delusional content. We didn't talk about excessive daytime sleepiness or the weight loss or the incontinence or these other sort of things that folks with Parkinson's have to deal with every day. And we just didn't even quite frankly, didn't address those things 25 years ago when I started practicing. So in the past, it's our understanding of the disease has increased tremendously, and our appreciation for the complexity of the disease and the difficulties that patients and caregivers go through has really increased.
And when you were saying with the non-motor skills, do usually the significant others and family members who are around those people, and they're able to explain some of the things?
Sure, absolutely. Yeah, a lot of times, there's another sleep disturbance for non-motor. I didn't mention there's a condition that's frequently seen called REM sleep behavior disorder. REM sleep behavior disorder is kind of like when your dog falls asleep on the floor and starts kicking and woofing, and you think, oh, how cute, he's running after a rabbit or something. People will kind of act out their dreams. There's our brain, when we go into REM sleep, is supposed to be essentially paralyzed, so we don't move, we don't run, we don't punch, we don't kick. But folks with REM sleep behavior disorder will act out their dreams. They may scream, they may holler, they may punch, they may kick, and that's something loved ones will sometimes bring to my attention, and sometimes I have to encourage them to bring it to my. I'll ask them specifically, does that happen? And then, oh my goodness, yeah, that sure happens.
Right. So what's the difference in Parkinson's and Parkinsonism? So
Parkinsonism is kind of a bigger umbrella, the way I think of it. And so so if a person has tremor, if a person has rigidity, if a person has slowness of movements or diminished movements, or a person has postural instability, that's Parkinsonism. The most common cause of that is Parkinson's disease, also known as idiopathic Parkinson's disease, because we really still, to this day in 2024, don't know why people get Parkinson's disease. So it's idiopathic, meaning that we don't know. There's also vascular causes of Parkinson's disease. There's medication-induced. There's exposure to chemicals can cause Parkinsonism. I just made a mistake there in my. Medication-induced Parkinson's, not medication-induced Parkinsonism, not Parkinson's disease. People who have been concussed repeatedly, boxers sometimes develop Parkinsonian features, and then also certainly sometimes people who've had anoxic brain injuries can develop a Parkinsonian syndrome as well. So there's other things that can cause it other than idiopathic Parkinson's disease.
Have you seen that if there are certain occupations or parts of the country, or it's just...
It's interesting. There seems to be a higher prevalence of Parkinson's disease in and around the Great Lakes region for reasons that are not entirely clear. There's an interesting heat map that I saw a couple of years ago, and it actually showed kind of, where the higher prevalences of Parkinson's disease, and it rimmed right around the Great Lakes. It is really an interesting thing, and we don't know why that is. There's a lot of research going on into where Parkinson's comes from, where do we get it. There's a lot of theories that it may come in through the air or come in through our food. Early Parkinson's pathology is actually seen in the gut, and we'll come back to that in a little bit later too. It's a really interesting thing. So it's not an infectious disease per se, but we're not sure why some folks get it and some folks don't.
Right. And physiology.
Sure.
And let's talk about that.
Sure. So basically, pathophysiology of Parkinson's disease refers to what's going on, what's going awry in the body to cause Parkinson's symptoms. And so what we see is that there is, for lack of a better term, it's a deficit of dopamine. There's not enough dopamine where it needs to be. And part of that is because it's of diminished production in the lower part of the brain stem called the locus coeruleus, substantia nigra. Also this results in less stimulation of the motor centers of the brain. And then there's also abnormal activity in the subthalamic nucleus, which is part of the basal ganglia. It's a really complex deal. What we see is that these different parts of the brain will accumulate these little abnormal pathological structures, which are largely alpha-synuclein, which is the major component of these Lewy bodies that are interrupting normal neuronal function in these different parts of the brain. The smoothness and the motor system that controls our movements are dysregulated as a result of these different parts of the brain being affected.
Right. So how does one get a diagnosis?
Well, usually a neurologist is involved, and that's what I do. There are special neurologists called movement disorder neurologists. Those are largely at academic centers. And basically it's a clinical diagnosis. It is history taking, physical examination, and testing to make sure, that there's not something else causing it more than anything else. It's kind of that old rule out sort of thing. Since it's a one-sided neurological syndrome, usually at the time of diagnosis, it tends to start off on one side or the other. You have to make sure there's not some sort of structural abnormality in the brain, and usually a CAT scan or MRI is done at some point to do that. But really, it's all about history and examining the patient. And so you look for the tremor, and you look for the stiffness or the rigidity in the muscles, and you watch the person walk, and you test their balance, and you challenge their balance. You have them stand up straight and tug on their shoulders and see if they can resist that sort of a push. There's a fancy test which is it's very good. It's called a DAT scan. DAT scan is a type, it's actually a trademark brand name. It's a PET scan.
Okay.
PET stands for positron emission tomography rather than a CAT scan or an MRI. And you can see in this picture, the one that has the comma shape is normal, and the one that has the two little polka dots is an abnormal scan. So it's pretty simple to see normal versus abnormal. And this is as good as, there's a study done a while back showing that a DAT scan is as helpful as a movement disorder expert in helping to sort out Parkinson's versus not Parkinson's. So it's a good test. It's not a necessary test to make the diagnosis. And I would say probably no more than 20 or 30% of the patients that I have with Parkinson's disease ever get a DAT scan. It's expensive, and it's not easy. It takes a whole day. It's quite an involved process.
And we have another slide that explains the diagnosis timeline.
Yeah, it's. I put this slide in there because I thought it was something that kind of really speaks to where we are with neurodegenerative disorders in general, but also with Parkinson's in particular, is that if you look at this figure, you can see the little circle where it says clinical onset, and the in the circle, and there's an arrow dropping down to where it says unilateral tremor, rigidity, akinesia, and that's TRAP. Those TRAP features I was talking to you about, and you can see that there's numbers down below that line. You're already between 3 and 4, and 3 and 4 is this Braak stage, B-R-A-A-K, and Braak is a very important neuropathological grading scale. So if you take a brain and stain it and slice it up and look at it under a microscope, you can do Braak staging. So this is not something that you do to people, obviously. But you can see that you're already halfway through the illness by the time you show up to the clinic. So you can see that before people get a Parkinson's diagnosis, there's frequently changes in their body habitus, changes in their sleep, changes in their behavior, and you can and so those things are present well before they get diagnosed. After they get diagnosed, usually there's about a 20-year time course. I frequently see people that are terrified of having Parkinson's disease. It's a scary thing. And when I tell them that they're looking at a 20-year time course, they're a little less terrified. They realize, this is a disease that we can manage. We can't cure it. We can't fix it. We can't make it go away. But we can try to improve the quality of life as much as possible for those 20 years that most folks are going to have. It varies from person to person. Not everybody makes it 20 years, but that's just the way medicine is.
Right.
But yeah, it's a very there's a tip of the iceberg is kind of the clinical symptoms, and then the 2/3 of the iceberg that's underwater is the neuropathological changes that we see with these degenerative disorders.
The Parkinson's Plus,
Yeah.
and Parkinson's Plus is not Parkinson's disease.
It's not Parkinson's disease, yeah,
Okay.
and that's the tricky part because that makes it much more challenging for us as the treating physicians and the medical team that are working with the patients and families, as well as for the patients and families themselves, because these are tougher to treat, and they are usually not significantly benefited by our current treatments. So you are unfortunately beholden to the natural history of the illness, which is relentless progression. Particularly in the case of the progressive supranuclear palsy, that's one that is very bad balance problems and eye movement problems and stiffness and difficulties with movement, and these folks just tend to end up in a wheelchair and or falling and getting hurt badly, and it's rough. Multiple system atrophy is similarly tough to treat. There's some things that are off-label that we can use that can help, and same thing with corticobasal ganglion degeneration or corticobasal degeneration, which is where there's other sorts of cortical deficits. People have difficulties with language or those kind of things, or performing tasks, and these are tough. They're, like I say, these are not these folks are not likely going to make it 20 years, and these folks are not likely going to see significant benefit from our treatments. So it's a lot more of accommodating the disability than anything else with those conditions.
So with those, so they're just completely treated differently?
Yes, absolutely.
Okay. But the treatment of Parkinson's disease.
Yeah. So there's several different prongs with Parkinson's treatment. The thing that I always tell folks when they come see me is that therapy and exercise is so important in this disease. It's every bit as important as the medications. The medications are symptomatic treatments. They are medications to attack the symptoms of the Parkinson's disease. They don't have an overall change in the clinical course of the disease as it progresses. So the maintaining good physical strength and endurance and exercising and those sorts of things is very, very important. There is surgical options. Surgical options are really limited to the major universities and those sorts of places, Cleveland Clinic, IU, University of Cincinnati, where there's deep brain stimulator treatment, which is the main thrust these days for Parkinson's disease. Also educating people about what they're facing, realizing that this is a marathon and not a sprint, and we need to take appropriate tacks. Focusing on good nutrition and keeping people healthy otherwise. If you have troubles moving, it doesn't help to be overweight. But these folks also tend to lose a lot of weight, so paying attention to protein needs and that kind of stuff as well is important. And then also, patients and families frequently have significant mood issues, whether it's depression, anxiety, confronting these sorts of challenges. And with Parkinson's, we know that a full 2/3 of folks have major depression. We need to treat those sorts of aspects as well.
And on the treatment of Parkinson's disease, we're looking at with the medical side.
Yeah. There's a lot of meds. And this is probably why neurologists are involved almost exclusively in managing these diseases. There's at least 14, 15 medications on the slide that we put up, I gave to you earlier. And these medications range from the kind of the gold standard, which is carbidopa, levodopa. It's actually that same old medication that in 1967 they gave folks with this shaking palsy, and lo and behold, it made a difference. A little shout out to Robin Williams' movie Awakenings, if you've ever seen it or haven't ever seen it.
No, I've seen it.
It's wonderful. It's a fantastic movie. And so that was the carbidopa levodopa story. Since then, there's been a dozen more medications that have come and that we still use. You target the treatments to the patient's individual symptoms, and then, like I said, the deep brain stimulation from a surgical standpoint is really where we're at today.
Some of the resources, and
Absolutely.
I'd be remiss if I didn't talk about Rocksteady Boxing.
Absolutely. Absolutely. Rocksteady Boxing is wonderful, and the Parkinson's Disease Foundation, is tremendous. Reid is super proud to be a recipient from a grant from the Parkinson's Foundation, and Rocksteady Boxing is expanding their services through that grant. It's wonderful. I'm tickled to death that they're here and that they do such a great job. Michael J. Fox Foundation has been huge for bringing Parkinson's disease in front of people and helping us to understand that that these folks are just like anybody else, and they need love and affection and attention and treatment just like any other disease. And the American Parkinson's Disease Association is another great organization. Rocksteady Boxing, Indiana Parkinson's Foundation, and there's a lot more information about Parkinson's disease at the National Institute of Aging website as well, and I put that on the slide. So, but yeah, it's a lot of resources, and local support groups are super helpful for patients and families.
We have a family friend who, I think the man stayed in his room for 2 years
I believe
after his diagnosis.
I believe it.
And now he's going to Rocksteady Boxing.
Good.
and he's out talking.
Nice.
And I was like, the man in the bedroom is actually talking to people.
It's so important. It's so important to get out and socialize and
Right.
interact.
And to get that socialization has really changed his outlook. And
there's a stigma. There's a stigma to it. You know, it's people realize that they get looked at funny when they don't walk right, when they shake. You know, the little kids that stare at you is one thing, but when grown-ups do it too, it can be kind of difficult to handle.
Yes.
And so the tendency to retreat is for real.
what would you like our audience to know? At least one thing, if nothing else.
It's not a death sentence. Okay. Parkinson's disease is not a death sentence. I think that's the most important thing that we all understand. That it's a tough disease. I'm not going to sugarcoat that, but it's manageable. You know, the prevalence of the disease, it's really about 1 in 1,000 people, and it's about 1% in people over age 65. So it's not a huge amount of people that are affected with Parkinson's disease, but it's also not a tiny number of people. You know, think about how many folks we all know that are over age 65, and 1 out of 100 of them is going to have it. So it's not a death sentence, and it's not anything to be ashamed of. It's nothing you did to deserve it. It is a condition. Everybody's got something. That's what I've been telling my kid from the time he was 2 years old. Everybody's got something, and this is something that a lot of folks have, and we need to treat them and help take care of them and do the best we can.
Okay. Well, we want to thank you, Dr. Spoljaric, for joining us today.
Well, thank you
on
very
Let's
much.
Talk Together. And thank you, our viewers, for joining us today on Let's Talk Together.
Let's shine by seeing the best in all of us and by treating you here, right in your hometown. Let's look out for each other. Let's stay healthy. Let's shine together.